Acid-base disorders, a practical approach. This is a simplified approach for acid-base disorders in clinical medicine. We will go over the basic physiology of acid-base balance, brief. Then acid-base disorders will be discussed and rules of compensation, some interpretation rules of major acid-base disorders, and solving clinical acid-base disorder. The primary investigation to identify acid-base problems in patients is to do arterial blood gases. The normal values for the arterial blood gases, the pH is 7.4, but the acceptable physiological range is 7.35 to 7.45. The PaO2, although it is outside our concern here, it should be minimally 80 millimeter mercury, but it's usually more than 90. The PCO2, the normal one, is 40 millimeter mercury, but again, the acceptable physiological range for that is from 35 to 45, and the normal bicarbonate level in the blood is 24 with an acceptable range of 22 to 26. Now the venous blood is not much different than the arterial blood. It's slightly more acidotic with an average pH of 7.36. The PCO2 is slightly higher with an average of PCO2 of 45 and a higher P bicarbonate with an average of a 26. Now the definition of acidosis or acidemia is an absolute pH of less than 7.35 and alkalemia of a pH of 7.45. Although from practical standpoint, a pH of 7.40 above 7.40 is considered. But from practical approach, a pH of more than 7.40 is alkalosis, and a pH of less than 7.40 is acidosis. Now, if you use the PCO2 and the bicarbonate and the pH to identify acid-base disorders, respiratory alkalosis is where the PCO2 is very low and the pH is high. And respiratory acidosis is the PCO2 is primarily very high and the pH is low. On the other hand, metabolic alkalosis is characterized by high bicarbonate and a high pH, whereas the metabolic acidosis, which is a common problem in clinical medicine, it is characterized by a low bicarbonate and low pH. Now, when we try to interpret the acid-base disorders, we need an arterial blood gases to obtain the pH, the PCO2, and the bicarbonate, and we would also need the serum chemistry for the sodium, potassium, and chloride to calculate the anion gas. It is very important to know the compensation rules for the respiratory and metabolic disorders in order to identify if this is just a simple acid-base disorder or this is a combination of acid-base disorders. So in simple terms, respiratory compensation, usually it is done for metabolic disorders. And these respiratory compensations, they start very quickly within 30 minutes and they usually peak in less than 24 hours. Whereas the metabolic acidosis, the patient have hyperventilation and a tendency to lower the CO2. In metabolic alkalosis, there will be a significant hypoventilation with a rise in the PaCO2. There are certain rules for the respiratory compensations that we should memorize to be able to identify the types of acid-base disorders. For example, for metabolic acidosis, the expected PCO2 will be 1.5 times serum bicarbonate plus 8, and this number is usually within plus minus 2 of the calculated formula. But the lowest PCO2 that can be reached is usually around 12 millimeter mercury. And the duration is limited due to respiratory muscle fatigue. The patient cannot maintain such high level of hyperventilation for a long time. They get fatigued. In metabolic alkalosis, you will notice a hypoventilation with the change in the PCO2 equals around 0.7 to 0.9 in change in the bicarbonate. I'll show you examples later on. And the maximum PCO2 is usually around 55 millimeter mercury. The renal compensation, on the other hand, occurs for respiratory disorders. For example, in acute respiratory acidosis, the change in the bicarbonate is around 1 milliequivalent for every 10 millimeter increase in the PCO2. So the delta bicarb is 0.1 delta of PCO2. So the PCO2 changes from 40 to 50, that's a 10 millimeter mercury change, the bicarbonate will change by 1. However, in chronic respiratory acidosis, the system is more efficient in the change in the bicarbonate for the change in the PCO2. So there will be increase of 3.5 milliequivalent of bicarbonate for every 10 millimeter mercury increase in PCO2. If the patient chronically increase the PCO2 from 40 to 50, the bicarb will increase by 3.5 milliequivalents. In acute respiratory alkalosis, the delta bicarb is minimal for the increase in the decrease in the PCO2. However, in chronic respiratory alkalosis, the change is more significant with the decrease of the bicarbonate by 5 milliequivalents for every 10 millimeter decrease in the PCO2. Another concept that we will go over is called metabolic acidosis. Metabolic acidosis is divided into a normal anion gap and a wide anion gap metabolic acidosis. So what is anion gap? Anion gap is the difference between the measured cations and measured anions in the serum. And the major cation in the serum is sodium, and the major anions is bicarbonate, chloride, and the hidden anions. So the anion gap is done this way. It's a sodium minus chloride plus bicarbonate, and usually it's around 10 milliequivalents from 9, 8 to 12 milliequivalents. If it's more than 15 or more than 20, that will indicate the presence of a hidden anions in the blood, as it's shown on the right side of the screen here. Now, the causes of wide anion gap metabolic acidosis are usually serious causes, and these tend to have an anion gap of more than 20. And that include methanol intoxication, uremia, diabetic ketoacidosis, peroxide overdose, isoniazide toxicity, lactic acidosis, ethylene glycol intoxication, and salicylate overdose. And you would memorize this from mud piles. That's how I memorize them. And most of them are these toxins that potentially fatal and associated with increased morbidity. So identifying a wide anion gap metabolic acidosis, we usually rule out lactic acidosis associated with sepsis, a septic shock, and hypoperfusion state, diabetic ketoacidosis, which is quite often seen in clinical medicine. And other than that, if you look at them, most of them are intoxication or overdose of certain medications. Whereas normal anion gap, metabolic acidosis with an anion gap is usually less than 15. The major causes are renal tuberoacidosis, diarrhea, urethral diversion, pancreatic fistula, saline resuscitation, hyperalimentation, acetozolamide, and amphotericin use. We'll shift gears to patients with metabolic alkalosis. Metabolic alkalosis is high bicarbonate and high pH. They are divided into what's called chloride responsive, which means the urine chloride is more than 20 milliequivalent, and they respond to normal saline infusion. And usually, the common cause of the metabolic acidosis that's chloride responsive is volume contraction, which is usually nasogastric suctioning, vomiting, diuresis, and these are common things in the medical wards and surgical wards more specifically. Post-hypercapnia metabolic alkalosis, hypokalemia related metabolic alkalosis, hypomagnesemia, and penicillin. From clinical practice, these are common. You would see nasogastric suctioning in patients who are made MPO for, let's say, upper abdominal surgery or paralytic areas, etc., and they have vomiting at the same time. Patients on diuresis in the cardiology wards who also will develop hypokalemia and hypomagnesemia. Now, the chloride unresponsive, where the urine chloride is low, commonly it's seen with patients who are on mineralocorticoid medications, which is exogenous steroids, patients who are prednisolone or methylprednisolone or hydrocortisone, patients who have patients who have mineralocorticoid excess from the adrenal gland, alkali ingestion, and something that can be missed, which is licorice. Some people like to do that, and Bartter syndrome. Now I'll go quickly over solving acid-base disorders. The first rule is we think when we think about solving acid-base disorder is decide what is the primary disorder, what is the primary problem, and we look at the pH. If the pH is more than 7.40, most likely the major problem is of alkalosis origin. But if the pH is less than 7.40, the primary disorder is usually acidosis. Now we look at the PCO2. If the PCO2 explains the pH, let's say the pH is 7.40 and the PCO2 is low, then this is a respiratory disorder. If the pH does not explain it, then this is a metabolic disorder. Then we apply the compensation rules that we talked about earlier. If this is compensated per the prediction rules, this is just a simple acid-base disorder. But if it is not compensated, then there could be a 2 or more acid-base. Now we'll go over some case studies. This is a 39-year-old woman who was admitted with a history of generalized weakness following severe diarrhea. Now, patients with severe diarrhea and frequent bowel motions, they are at risk for developing what kind of disorder? They are prone to develop metabolic acidosis of the normal anion gap. So let's look at the results. The pH is 7.29, the PCO2 is 26, and the PO2 is 98. So the pH is low, less than 7.40. The PCO2 is on the low side. It does not explain this acidosis, so most likely it's a metabolic. We'll look at the bicarb. The bicarb normally is 24, here is 12, so this is a metabolic acidosis. Now the compensation rule for the metabolic acidosis is 1.5 times the bicarb plus 8, so it is 25, and the patient PCO2 26, so this is a simple compensated metabolic acidosis. Now what is the anion gap? The anion gap is 10. It is sodium 125 minus chloride 103 plus the bicarb 12, so it's 10, so it's a normal anion gap metabolic acidosis. Most likely the diarrhea is causing this acid-base disorder. Case number 2, this is a 78-year-old lady who presented with at least a week history of abdominal pain and vomiting. Her ABG is 7.49, PaCO2 of 52, and a PO2 of 78. So abdominal pain and vomiting, we talked that vomiting causes metabolic alkalosis, usually of the chloride responsive type because of the contraction, the volume contraction. And this patient has vomiting and abdominal pain could be acute cholecystitis or any other GI problem like pancreatitis. So from the ABG, the pH is high and the PCO2 is high, so this is a metabolic of origin. This is the bicarb is 38, so this is a metabolic alkalosis. The urine chloride is 43, so this is a chloride responsive metabolic alkalosis. This is compensated. The compensation rule is the delta bicarb or the delta PCO2 is 0.9, the delta bicarb. The delta bicarb is 14 times 0.9, it's 12.6. The PCO2 is 40 plus 12.6 is 52.6, so it is around the compensation rule, which is PCO2 is 52. So this is just a simple chloride responsive metabolic alkalosis that can be corrected by normal saline infusion. Case study number 3. This is a 40-year-old man with ischemic heart disease and depression who presented in the emergency room with hyperventilation and dyspnea. His ABG electrolytes have been drawn by the nurse and show a pH of 7.38, that's a mistake, and PCO2 of 18. So if you look at this ABG, 7.38, it's on the acidosis side, but at the same time the PCO2 is low, so the PCO2 does not explain this pH. So I will look at the bicarb. The bicarb is extremely low. The normal is 24, now it's 12. I would expect the pH to be much lower than this. Then there must be two disorders they're trying to balance this. And the way we analyze this, first of all, we look at the anion gap. The anion gap is 143, which is the sodium, minus the chloride 106 and the bicarb 12 is 25. So there is a wide anion gap metabolic acidosis. Whenever there is a wide anion gap, there is a metabolic acidosis in the background going on. So what are the causes of wide anion gap metabolic acidosis? Mud piles. We talked about lactic acidosis, diabetic ketoacidosis, methanol, ethanol, ethylene glycol, and aspirin intoxication. So this is an wide anion gap metabolic acidosis. At the same time, we look at the compensation rule for the metabolic acidosis. 1.5 times 12 plus 8, they give you a CO2 of 26, but the CO2 is 18. It's much lower than what it should be. Then there are two primary disorders. There is a wide anion gap metabolic acidosis, and there is respiratory alkalosis causing the PCO2 to be lower than 26. So whatever this patient took caused metabolic acidosis of the wide anion gap and respiratory alkalosis. And we know that aspirin overdose does this causes this combination of metabolic acidosis and respiratory alkalosis. So the patient has been overdosing on. Now we'll shift also to respiratory acidosis, acute versus chronic. In acute respiratory acidosis, the change in the pH is 0.008 times the change in the PCO2. In the acute phase, in the chronic phase, the delta pH will be 0.003 times the change in the PCO2. So if you have a patient whose PCO2 is 55, so the change is from 40 to 55 equals 15. So if this is acute, the change will be in the pH of 0.12, so the pH will drop to 7.28. If it's chronic, because there will be a metabolic compensation or renal compensation, the change will be less and the pH will be 7.355. So if this is a patient who presented to the emergency room with a PCO2 of 55, which is high, and the pH is 7.36, this is a chronic, stable problem that I should probably not worry about it too much. But if he or she present with a pH of 7.28, it is an acute problem that I probably should pay more attention to it. On the right side, this could be a patient with COPD, stable COPD, with a bad lung disease that's causing a chronic rise in the CO2. This could be a patient with a neuromuscular disorder that slowly his or her CO2 has been increasing, whereas the one on the right side, it could be an acute exacerbation of a lung disease or acute deterioration of a neuromuscular disease that I should pay attention to and address acutely. Case study number 4, a 60-year-old man who presented to the ER with dyspnea and wheezes. He's a heavy smoker, and ABG and electrolytes were drawn by the nurse. His ABG is pH 7.33 and a PCO2 65. Whoa, the CO2 is high. It is higher than it should be, 40, and the pH is lower than it should be, which is 7.40. So this is acute or acute on top of chronic or a chronic respiratory acidosis. We apply the rules. The delta PCO2 is from 40 to 65 is 25. You multiply it by 0.08 for the acute, that will give you a pH of 7.20 and 7.320 for the chronic. The patient 7.33, so this is a chronic respiratory acidosis. So this patient, although he's presenting with dyspnea and wheezes to the emergency room, there is no major change in his acid-base disorder, and most likely whatever he's presenting with is mild and can be managed most likely in the emergency room. By this slide, I will complete my presentation. As you just noticed, this is just a simplified approach, practical approach to acid-base disorder for fourth-year medical students. If any of you have any question, they can approach me at any time and I will be happy to answer it, and thank you. Pulmonary function tests. This lecture will address several objectives for pulmonary function tests for fourth-year medical students. We will go over the types of pulmonary function tests, the basic physiology of spirometry, interpretation of spirometry and lung volumes, diffusing capacity of carbon monoxide, algorithm for spirometry and PFT interpretation, and some clinical cases. The indications for spirometry in clinical medicine is first to evaluate of symptoms and signs or abnormal investigations of the respiratory system. For example, such as symptoms of cough, dyspnea, wheezes, orthopnea, sputum production are symptoms suggestive as asthma, COPD, interstitial lung disease, and spirometry is very important to help with the diagnosis and assess the severity of these disease. Signs, for example, patients with chest deformity, patients with cyanosis, patients who have wheezes, crackles, and should be investigated. Investigations of unexplained hypoxemia or hypercapnia or polycythemia or abnormalities seen on chest X-ray or CT scan. So it will help to establish the diagnosis using symptoms, physical signs, and some investigation abnormalities. Spirometry and PFTs are used to follow the course of disease and assess the prognosis, For example, some diseases are progressive, like chronic obstructive lung disease and interstitial lung disease. So spirometry is one of the major criteria to follow the disease progression and decide the prognosis. It is used to screen for individuals at risk. For example, chronic smokers, cigarette smokers, they are screened for COPD, occupational exposures. Some of these occupations, they need frequent or scheduled PFTs to assess the risk of interstitial lung disease, use of certain medications like amiodarone or bleomycin. Neuromuscular diseases like myasthenia gravis and Guillain-Barré, they need vital capacity to assess their possible progression into respiratory failure. Also, spirometry and PFTs are helpful for pre-operative risk assessment in patients who specifically will undergo lung surgery like lobectomy, pneumonectomy, etc. Also, spirometry and PFTs are invaluable tool to assess the response to medical interventions and treatments in asthma, COPD, interstitial lung disease like sarcoidosis, etc. Spirometry is a essential component in the diagnostic criteria for important and common diseases, like the gold criteria for diagnosis COPD, on top of the symptoms and the exposure to cigarette smoking. A post-bronchodilator FEV1 and FVC less than 70 is essential to diagnose persistent airflow limitation and diagnose COPD. And for the GINA Global Initiative for Asthma guidelines, on top of the typical symptoms and pattern in patients with suspected to have asthma, the presence of reversible airflow limitation and obstructive defect is essential to diagnose asthma. Generally, spirometry is used to classify diseases according to obstructive pattern and restrictive pattern, common causes of obstructive pattern, which we will talk about. In the next few slides is mainly asthma, COPD, bronchiectasis, and cystic fibrosis, alpha-1 antitrypsin, which we don't see often in Jordan. The restrictive pattern is usually consistent with diseases of the interstitium like lung fibrosis, sarcoidosis, kyphoscoliosis, neuromuscular weakness, and marked obesity. When we perform spirometry, we look at three important parameters. The first one is the force vital capacity. It's called FVC, which is the volume of air that can be forcibly blown out after full inspiration, and it is actually the difference between total lung capacity and the residual volume. So the patient starts with total lung capacity and exhale forcefully until no more volume can be exhaled, which is the residual volume. This difference is called force vital capacity. The forced expiratory volume in the first second, when we do this force vital capacity maneuver, the volume that is exhaled the first 1 second is called FEV1, and it's important to identify patients with obstructive lung disease. And the ratio of the FEV1 and FVC is a percentage volume, percentage ratio that should be helpful to identify patients with obstructive lung. So spirometry, it's performed using devices in the pulmonary function lab. These could be large, sophisticated devices, or it could be very simple devices that can be even attached to a laptop. And what we do is we ask the patient to inhale to maximum inhalation, where they cannot inhale any further, and this would be their total lung capacity. Then we ask to exhale forcefully until they cannot exhale anymore, which is the residual volume. And during this maneuver, we measure the force vital capacity, the FEV1, and the peak expiratory flow, and I'll show you that in the graph. And we repeat that for a minimum of 3 times and up to 8 times until we get the best 3 maneuvers. From them we calculate the FVC, the best FVC, the best FEV1, and from that we get the FEV1 FVC ratio. So if you, this is where the patient start, this is the total lung capacity, they exhale forcefully until they reach the peak expiratory flow, then there will be deceleration of the curve until they reach the residual volume, then they take a deep breath and they'll go back to the total lung capacity. This is called the flow volume loop. The time volume curve is very important too in identifying the FEV1. So the patient here will start with the total lung capacity, then they exhale forcefully until their plateau at least 6 seconds. And this is the forced vital capacity, and or they call it FEV6 because it's done at 6 seconds. And this is the FEV1, and you divide this number, which is close to 4.8 or so, divided by 5.9, and they give you the FEV1 FVC ratio. The normal values are derived from reference values that are done on normal people, and these numbers are stored in the computer of the PFT machine. So once you start doing the test, you enter the patient's race, age, height, and gender, and the machine will generate a normal forced vital capacity, FEV1, FVC ratio reference numbers. And the lower limit of normal for these numbers is around 80%. So the FVC, the FEV1, and the ratio should be more than 80%. And the same for the DLCO, total lung capacity, which we'll go over them. Now, when we're trying to interpret the spirometry, we're trying to decide the patient has obstructive, restrictive, and sometimes they have a mixed obstructive, restrictive. The interpretation algorithm is very simple. We first look at the FEV1 FVC ratio. If it's more than 80%, which we consider normal, we looked at the vital capacity, the forced vital capacity. If it's more than 80% normal, so this is a normal test. Normal FEV1 FVC ratio, normal vital capacity, this is a normal test. But if the FEV1 FVC is more than 80% and the FVC is less than 80%, this could be a possible restrictive lung disease, and further testing is needed. On the other side, if the ratio is less than 70% or less than 80% by other definition, then we look at this is most likely an obstructive lung disease. But we first will look at the FVC. The FVC is normal. This is a pure obstructive lung disease. So obstructive lung disease is the FEV1 FVC less than 80 or 70 by other criteria, and the FVC is normal. What about if the ratio is less than 70% and the FVC is low? Then this could be a mixed defect in obstructive plus restrictive lung disease, or could be just a severe obstructive lung disease with air trapping. So when we do interpretation, obstructive lung disease, the FVC, FEV1 FVC ratio is less than 70 or 80% by other criteria, and the FEV1 is decreased and the FVC decreased in severe obstruction. Whenever you suspect restrictive lung disease, if the ratio is normal or increased and the FEV1 FVC is decreased, and the FEV1 could be also normal or decreased. I don't want to confuse you with the slide, but the obstructive lung disease pattern is normal ratio. This is the hallmark. And the hallmark for restrictive lung disease is a normal ratio and decreased FVC. Now, we have lung volumes to measure to supplement our PFT interpretation. And we can do that by either helium dilution or nitrogen washout, or in body plethysmography, which is shown on the, we call it the box, shown on the body box shown on the left side. We are interested in these lung volumes: total lung capacity, the FRC, which is the functional residual capacity, residual volume, inspiratory capacity. The normal values or lower limit normal for them is more than 80% predicted. Now, when we add lung volumes to the interpretation, we can use these rules. A low FEV over FVC less than 70% or less than the lower limit of normal, which is 80%, is obstructive. Low total lung capacity less than 80% or less than the lower limit of normal, it's restrictive. If you have both low FEV1 FVC, low ratio, plus low total lung capacity, this is a mixed obstructive restrictive lung disease. Then again, the hallmark for obstructive lung disease is a low FEV1 FVC ratio. The hallmark for restrictive lung disease is a low total lung capacity. The hallmark for a mixed pattern is the combination of low total lung capacity and low FEV1 FVC ratio. The diffusing capacity for carbon monoxide, our lungs are naive to carbon monoxide, especially if we don't smoke. So the measurement of the ease of transfer of carbon monoxide from the alveolar gas to the hemoglobin in the pulmonary circulation is measured, where the results are volume and hemoglobin adjusted. Now the interpretation, the simple interpretation of the DLCO, if it is low DLCO and normal spirometry, you would think about anemia, pulmonary vascular disease, chronic thromboembolic pulmonary disease, and early interstitial lung disease or early emphysema. So early interstitial lung disease, early emphysema, chronic thromboembolic pulmonary disease, pulmonary vascular disease, anemia are causes of low DLCO with normal spirometry. If the spirometry showed restrictive pattern with low DLCO, you would think about interstitial lung diseases like sarcoidosis and IPF. If the DLC is low and there is an obstructive pattern, you would think about emphysema. On the other side, a high DLCO can be associated with asthma, obesity, and intrapulmonary hemorrhage. The normal DLCO can occur with restrictive lung disease if it is caused by chest wall abnormalities or neuromuscular disorder. So a low total lung capacity and a normal DLCO indicates extrapulmonary cause of restrictive lung disease like chest wall abnormalities and neuromuscular disease. Another way that the American Thoracic Society and European Respiratory Society, they look at the normal values of the lung function, they use the 5th percentile as the lower limit of normal range for these values. So they call it the lower limit of normal. Lower limit of normal is the mean predicted value based on the patient gender, patient age and height, minus 1.64 times the standard error. So this is the lower limit of normal, 1.645. So if the patient is below this number, is considered abnormal. So this is another algorithm that help you in the interpretation of a spirometry, integrating spirometry, lung volumes, and DLCO. And I'll walk you through this. So if the FEV1 FVC is more than the lower limit of normal, so it is normal, that is yes. And the vital capacity is normal. So normal ratio, normal vital capacity, normal ratio, normal vital capacity. This is a normal test. If its patient still has symptoms, then we should do a DLCO. If the DLCO is normal, this is a normal patient. If the DLCO is low, then you think about isolated pulmonary vascular disorders like pulmonary hypertension. If the ratio is normal and the vital capacity is low, then we should suspect the presence of restrictive lung disease. So we do a total lung capacity. If the total lung capacity is low, then this is a restrictive lung disease. And patient with restrictive lung disease could be intrapulmonary or extrapulmonary, and that's when we do a DLCO. If the DLCO is low, then you start thinking about intrapulmonary disorders. If the DLCO is normal or high, you think about extrapulmonary like chest wall abnormality and neuromuscular disorders. Now, if the ratio is below the lower limit of normal, then you would think about obstructive lung disease. First of all, we look at the vital capacity. If the vital capacity is normal, this is just a simple obstructive lung disease. You do a DLCO. If the DLC is low, it's emphysema. If the DLC is normal, you would think about asthma. If the vital capacity is low and the ratio is low, then you think could be a mixed disorder. There could be the presence of obstructive lung disease, severe form, or obstructive lung disease with interstitial lung disease. Then you do a total lung capacity. If the total lung capacity is low, then you're talking about a mixed disorders, a obstructive lung disease and restrictive lung disease, like the combined emphysema, lung fibrosis, lung disease. If the total lung capacity is increased, then this is most likely obstructive lung disease. And again, you do a DLCO. If the DLCO is low, it is more emphysema. If the DLC is normal, of asthma. I know that this may seem confusing, but if you walk yourself through this diagram several times, you will get to the point of it's a very simple, straightforward interpretation. Now, the severity of obstruction, it depends on the guidelines. For example, the Global Initiative for Obstructive Lung Disease guidelines, they classify the severity of obstruction as a mild COPD if the ratio is less than 0.7 and the FEV1 is more than 80%. It is moderate if it's 50 to 80%, severe if it's 30 to 50, and very severe is 50%. Now, when we try to differentiate between asthma and COPD, we talked about one of them is the DLCO. The DLCO is low. It's most likely emphysema. If it's normal, it could be asthma, but it could be also chronic bronchitis. And some people use the bronchodilator response test, which is the assess. What we do is we assess the lung function of spirometry at the baseline. Then we give the patient 4 separate doses of 100 micrograms of salbutamol using meter dose inhaler and a spacer. Then we wait 15 minutes. Then we repeat the spirometry. If there is an increase in the FEV1 and or FVC of 12% and 200 ml, so if there is a change of 12% and 200 ml, this is a positive bronchodilator response, and this is more likely to indicate asthma. The shape of the flow volume loop help you to identify patients with, for example, moderate or severe obstruction. The curve on the left side, this one is normal. This is a concave curve that indicates the presence of mild obstruction. The shorter the curve, the more the concavity, it indicates severe obstructive lung disease. Whereas the restrictive lung disease, the curve looks like the normal, but it's miniaturized, it's smaller. This is a normal spirometry. If you look at this patient, has an FVC, FEV1 of 85%, so this is more than, this is the lower limit of normal 70, so it's more than the lower limit of normal. Then we go directly to FVC, which is 3.2 liters, which is more than the lower limit of normal 2.42, and it is more than 80% predicted. So this is a normal FVC, this is a normal FEV1 FVC, this is a normal test. On top of that, we look at the FEV1, which is also more than the lower limit of normal, and 108% predicted. So this is essentially a normal spirometry. This spirometry shows an FEV1 and FVC ratio of 54%, which is less than 70%. So this is obstructive, and also it is less than the lower limit of normal, which is 72. So this is by the two criteria. It is below 70%. So this is most likely an obstructive lung disease. We're going to look at the FVC at the same time. FVC is 6 liters. It is not below the lower limit of normal. It is 114% predicted. So a normal FVC, an FVC, FEV1 FVC less than 70%, this is an obstructive pattern. If you look at the FEV1, it is less than the lower limit of normal and 75% predicted. So this is an obstructive lung disease. Now we give the patient a bronchodilator. What happened to the FEV1? It changed from 3.31 liter to 4.765 liter, and this is a 40% change. And similarly, the FVC did not change actually, but the FEV1 improved by 12%, more than 12%, this is 40%, and more than 200 ml actually, it is almost 1.34 liters. So this is a obstructive defect that normalized with bronchodilators. So this is most likely bronchial asthma that responded to bronchodilator therapy. If you look at this example too, the FEV1 FVC ratio is 87, which is more than the lower limit of normal and is more than 80%. So this is a normal FEV1 FVC ratio. We go straight to the FVC. The FVC is 0.9 liters, which is very low. It is much lower than the lower limit of normal and is 28% predicted. So this most likely a significant restrictive lung disease. The FEV1 is actually 0.78, so it is lower than the lower limit of normal and 30% predicted. So this is most likely represent a restrictive lung disease. And this patient, to confirm the diagnosis, needs a total lung capacity, which is the gold standard for diagnosis of restrictive lung disease, and he also or she need a DLCO to differentiate between an intrapulmonary or extrapulmonary cause of restrictive lung disease. This is another example of patient with bronchodilator response. You see that the ratio is 68, which is less than the lower limit of normal, which is 75, and the FVC is 5.1, which is higher than the normal, which is higher than the lower limit of normal, and the FEV1 is 3.55, which is less than the lower limit of normal. So this is an obstructive lung disease, and after bronchodilation, the FVC improved from 68 to 70 FEV1 FVC, but still below 80%. The actual FEV1 improved from 3.55 to 4.64, which is a 30% improvement, more than 200 ml. So this is a bronchial asthma, and you'd see the curve obviously almost normalized. A few words about the upper airway disease. Upper airway disease or upper airway narrowing. If it's extra thoracic and it is variable, when the patient inhales, the inhalation limb of the spirometry loop will be flattened like this. So this indicates a variable extrathoracic airway obstruction. Whereas if it's intrathoracic, during exhalation, it will be flattened, the curve. This is a cause of variable intrathoracic external obstruction. If it's a fixed obstruction, whether it is extra or intrathoracic, both the inspiratory and the expiratory, limb will be flattened or box shaped, like patients with tracheal stenosis.